So great. So we're now going to move on to the management of ADHD. And when you have somebody where the diagnosis has been made, and in our context, you probably would not start people on ADHD treatment. So ideally, this should be done by the psychiatrist. But there's some basic things that will have to happen at baseline that you might need to be aware of, or you might want to do before you send them to the psychiatrist. So obviously, you're going to take a full medical and history, examine the patient to make sure there's nothing else going on. Please remember, oh, sorry, that's PHQ-9, to do your PHQ-9 and your GAD-7 to screen for depression and anxiety, because it might be, the one might affect the other and they might be related. Relevant blood tests according to your examination, but probably the 2 blood tests that's useful to do is just to make sure they're not hypothyroid or hyperthyroid and just check the hemoglobin. It's good to check for vision and hearing because that might affect behavior as well. The OTs are quite good at doing a sensory profile where they actually look at which senses are more or less sensitive. If we're going to give stimulants, we do need to watch out for heart disease. So especially if there's any family history of heart disease or the patient has any other risk factors, you would want a baseline ECG. And atomoxetine, which is one of our non-stimulants, can affect the liver, and then you would do a baseline liver function test. So our treatment goal is basically symptom relief and working towards optimal functioning. And basically what these treatments do is they help us focus. And I'll show you that in a minute. So pharmacotherapy is actually the cornerstone of treatment for ADHD, especially in adults. So it's very important also the coaching side and helping people cope with managing a neurotypical world with an ADHD brain. But actually the coping mechanisms on their own, sometimes, like they've got these lovely planners for ADHD people, and then they usually lose the planner or don't respond to the messages. So the stimulants together with the planner helps very much. And we've got sort of 3 major options. So the stimulants by far the most popular, and those are the 2 that's in our guideline. The non-stimulant in our guideline is atomoxetine, and then the non-pharmacological treatment options. The response rate is very high. So 70% in medicine is a very good response rate. It's probably a little bit better than even the use of antidepressants for depression. We have got most of our data on the stimulants, and they're still our first choice. The idea with adults is you're going to continue treatment as long as clinically possible. So it can potentially be lifelong treatment, but usually it has to do with what you end up wanting to do and you want to have an annual review to see how they're doing on that. And very important, so everybody's very paranoid about the potential substance abuse of these drugs. What's interesting in ADHD people, especially if you start stimulants earlier, it actually reduces long-term substance abuse. So it's not an entry drug because of the way it works on the brain. The problem is much more of those drugs getting diverted towards people who do not have ADHD and using it for its dopamine reward system. So if we look at the ADHD brain, remember we had that glitchy switch. And remember we said that dopamine is the thing that's not flowing properly, and that actually if we can get the dopamine reward system to go, actually it helps them to focus. So the one way to get somebody with ADHD to focus is show them something really, really interesting, something they really, really get excited about. But there's some things that can do that as well. So stimulants is the one that we know. So cocaine, amphetamines, all of those stimulate this dopamine reward system. And what it does is it helps you focus. So it takes you out of scattered focus and it takes you to focusing on something very specifically. Caffeine and energy drinks also does that. So we all use caffeine and energy drinks to get ourselves into TPN mode. And a lot of people with ADHD self-medicate themselves with those. And then exercise, 20 minutes of vigorous exercise actually improves cognitive functioning. Similarly, by working on this dopamine system. So the most one we all know is, of course, methylphenidate, which is our Ritalin. There's both short-acting and long-acting drugs. You can see it's in our pediatric STG. We only have the short-acting Ritalin because the long-acting is dreadfully expensive. They make a whole case for it in the EML, so we only have the short-acting as a possibility. It's effective in 57% of adults in some of the studies, some studies even higher. And the higher the dose, the better it works. It's very much a dose-related thing. There's a general recommended dose of 1 milligrams per kilogram per day. And it works very quickly. So most people will use it sort of 2 or 3 times a day, works within an hour, lasts 3 to 6 hours. So kids at school, for example, will take holidays from it. So when you're on a holiday and you want to be Calvin and Hobbes and be out and going wild, then you don't need to be on your Ritalin. But if you're in school and you need to sit down for that week, then you use Ritalin from Mondays to Fridays, and you can do that. It's extraordinary what it helps to do is it helps them to get on task with behavior. So it makes you less distractible. It makes you less, it helps definitely for academic performance and occupational problems. It improves social functioning, emotional regulation. It improves marital discord in the one study because it helps one to actually focus and being able to be present instead of being in that scattered focused daydream mode. There are side effects because it is stimulants. So dissimilar to caffeine, you can have reduced appetite, palpitations. It can make some people a bit more nervous. And so therefore what tends to happen is that people usually start on the short acting until one gets a dosing that works for you. And then the long acting extended release actually has less side effects and less discontinuation issues. It's a bit of a lower abuse potential as well, better adherence, obviously, especially in adults. Doesn't remember they have to take it regularly and they forget to take it. And so usually one would start with a short acting and then move them on to the long acting. So this is the issue, is the methylphenidate misuse, and this makes it extremely difficult. So I've looked at 2 little studies in South Africa. The one was on medical students at the University of the Free State, and they found that 11% of the surveyed students had used methylphenidate at some time. Less than a third of those had actually been diagnosed with ADHD, mostly for academic purposes. And look at that, 70% of them got it from a medical professional. So the students are very good at playing the systems to get hold of their Ritalin. And then in MEd students, so there was 253 also a survey that they looked at there. 28% have used methylphenidate to try and get them through their MEd, and only 2.4% of them had actually been diagnosed with ADHD. The problem is if you don't have an ADHD brain, so in an ADHD brain, there's the glitchy switch. So the dopamine just helps to sort out the switch. But if you don't have a glitchy switch, you can get very used to that dopamine reward like you would with cocaine or amphetamines. And so therefore it has this addictive potential in people who do not have ADHD. And that makes it a real challenge for us as clinicians who prescribe these things. So there's some street names: Diet Coke, Kitty Cocaine, Kitty Coke. So there's a whole market for it. And I think more of a worry, obviously, also somebody who then comes and gets their ADHD drugs, but needs food and then sells his Ritalin that he actually needs on the open market to get some money. So the other one is lisdexamphetamine or Vyvanse. It's a long-acting amphetamine. It has this active metabolite. It's effective, well tolerated in adults, not less dosing information on the under 12, so it is for slightly older people. And it actually has less recreational use because it's not short acting, it's a long acting, sort of more steady release dosing. So one can use it if you're concerned about people who already have substance abuse problems. Also can have obviously insomnia and irritability, just like all the other stimulants. And with amphetamines, there has been post-marketing reports of psychosis, aggression, depression, exacerbation of tics, and cardiovascular problems. So we have to have a more careful medical look at those patients. And I think Vyvanse is quite popular also in the private market. So it's usually between Ritalin and Vyvanse. What's becoming more and more popular now is a new non-stimulant called atomoxetine or Strattera. It reduces the reuptake of norepinephrine, so a very different way of working than the stimulants. There's mixed evidence. So initially it was thought to be less effective than Ritalin, but apparently some of the newer data actually looks quite encouraging, and it's probably underutilized. But certainly if you have somebody who's got ADHD who's already misusing substances, or you're worried that this guy might actually go on and sell his Ritalin, then atomoxetine will be a better option. You can see it's about 300 Rand a month. Also has comorbid, you can use it in people with comorbid anxiety disorders or severe tics where you don't want to use those stimulants. What's different with this is it doesn't work immediately. It's a bit like an antidepressant. So it takes about 4 to 6 weeks to actually click in. So you have to counsel your patient properly. And it's probably one of the reasons why it hasn't compared as well as Ritalin in the studies. And it also has a range of potential side effects, as all these things do. So there's other non-stimulants, but none of these are registered in South Africa. In the private market, though, imipramine is quite easily available. There's no evidence that I can see on amitriptyline, but that's quite interesting. So there is some evidence on the use of imipramine, especially in children. Venlafaxine has got some good news, but again, that would be off-label use, as well as bupropion. That's Wellbutrin that we also use for cigarette smoking. And then these other drugs are all in the market, but we don't actually have any useful information in adults, so not to be used. But these are all that is off-label use of those drugs, but they're non-stimulants as well, so a bit easier. Very important is your non-pharmacological treatments and being able to get your patient either to meet up with a psychologist, but occupational therapy can be extraordinarily helpful. So having an occupational therapist that helps to coach them in terms of how do you deal with chaos. And it's not always about teaching somebody to organize. It might be getting somebody to get past their shame of actually getting a cleaner in. It's a bit like having glasses when you can't see. If you can't organize, get somebody else to come and organize, get a PA, find ways to actually work with those challenges. There's some evidence on neurofeedback, and then there's very good evidence on exercise, both on the day. So if you want to concentrate well, go and do your 20-minute of exercise and then sit down and study. But also if you regularly exercise, it overall improves the ADHD symptoms. And then in the complementary and alternative medications, the only things that's shown any benefit is free fatty acid supplementation. So omega-3s, there's a little bit of benefit. And if you are sensitive, to exclude artificial colorants, but it's only if you are sensitive to those. Just a last thing on special populations. So in patients who've got severe anxiety and severe psychosis, you're obviously going to want to manage those first. But if they've got mild depression or mild anxiety, then actually start off with your ADHD treatment, because that actually might make things a lot better, and then see if you need to treat those. Anybody who's obviously got a psychotic disorder, you're not going to use your stimulants and rather try and use one of your others. And the same with the substance abuse disorders. And then we don't have much information in terms of pregnancy and lactation. It's still a category C drug. And so between an obstetrician and a psychiatrist, they will have to have a risk-benefit assessment to decide whether to continue the Ritalin or not. So in conclusion, start thinking a little bit about ADHD in patients who are either stressed, depressed, anxious, burnt out, exhausted, substance abuse. I had 2 weeks ago, the first time a patient came to me thinking he has got ADHD, a 23-year-old boy. Called the psychiatrist here at CMH. They were very confused about what to do about ADHD with adults. So at the moment, that's not an option. And we've actually referred them to the occupational therapy department rather in terms of support. Do refer please don't diagnose or start treatment yourself. It's a little bit of a challenging, with the challenges with the methylphenidate. And we need to be, the biggest thing one can probably do for somebody with ADHD is psychoeducation, and being affirming and supportive of how their brains work. And you can send them this video. Thank you very much. Those are my resources, the 2 textbooks that I used, as well as the guidelines. Thank you, everybody.